Welcome everyone to our AKCI KCA monthly didactic lecture series. Couple announcements before we start. I don't remember the last time we met if we had gotten notice that we're officially funded for 5 more years, but we got that notice. So thank you, Vince. I see him on here. So the current 5 years runs out in September, so we'll pick up from there. Thank you. Thanks for all your help, everyone. And our next quarterly meeting, I think, is July 9th. And so I'll send out an email about this, probably after ASCO, but I think we'll have the second years present, and then maybe, I don't know if Suchi Gulati's on. She couldn't do it last time, probably her as well. So anyway, I'll turn it over. Pleased to be joined today by Raqui Hannan, who's a radiation oncologist at UT Southwestern, who's been involved in all things radiation for kidney cancer for as long as I can remember. And I think you're all aware clinically. I remember when I was in Cleveland, gosh, it's probably 10 or 15 years ago when SBRT first came around for lung cancer, for localized lung cancer. That's how I remember it. And then talking to my radiation oncologist, and we started doing it in kidney cancer. And Raqui and UT Southwestern, I think, has been the leader in this, in my opinion. But we use it a lot clinically. I think there's a lot of areas of debate and controversy about when and where and all that. And so he's going to talk about SBRT, or also known as SABR, for kidney cancer. So Raqui, thanks for joining. We really appreciate it. I'll turn it over to you, and the floor is yours.
Perfect. Thank you so much, Brian, for the introduction. And it's really a pleasure to come and talk to the trainees. Not very often, frequently, we get this opportunity to take some time and explain exactly what we're doing and why we're doing and how we're doing. So this is going to be the outline of my talk. And as I was telling before, a bit more clinical, but there is some translational aspects that I'll highlight. And we don't have to cover everything. I will see my target is to be able to cover the first portion where we talk about primary kidney and application of SBRT. And then if we have time, we'll go a little bit into metastatic. Or if not, we can always cover that in the future. So I wanted to take a little bit of time to explain what SBRT is and what SABR is. So as you know, did you know that there is no such thing that a tumor that cannot be eradicated by radiation with high enough dose to the tumor? It destroys all cellular processes in the tumor cells, and all cells can be killed with radiation. So then naturally you would ask, then why don't we just kill every cancer? You could just take out everything, right? The problem, of course, is collateral damage. So collateral damage has plagued radiation therapy for over 100 years, and the normal tissue suffers the same fate as the tumor. And what tumor cells cannot tolerate is also not tolerated by the surrounding organs, and hence you cannot just go ahead and give high doses of radiation to kill every tumor. But how do we focus the radiation? We know that radiation is light, right? It's electromagnetic waves. It's just higher end of the spectrum using gamma rays that have high energy that lets us penetrate screen and deposit inside. But it does not bend. It travels in a straight path, and the same principles of physics applies here. So how do you do it? How do we target a tumor that is, one, a moving target, and second, is surrounded by all normal radiosensitive critical organs? And the answer to that is magic, of course. Magic is the technology of magic. Now, I will today take you behind the scene on the magic of how it happens and how we do it. And the one thing to understand is we call it SABR, which is very synonymous to SBRT. The umbrella term here is the stereotactic radiation. It's a technology also used by some companies like CyberKnife, Gamma Knife. You may have heard, all of them are using the stereotactic technology. And I may use the terms SABR and SBRT interchangeably, and that's the same thing in the field. But the key thing to understand here is it is built upon technologies that was developed previously, and it is a culmination of all the technology that you may have heard. You have heard about 3D CRT, IMRT, IGRT. We'll go over briefly all of them, and we will tell you exactly how they are done and how each of them leads up to stereotactic radiation. Eventually, I'll talk a little bit about the latest advance, which is pulsar, bringing in adaptive technology. So how does it start? It starts with beams that you're bringing in from different direction. Okay, so you can imagine, so to read radiation plans, we depict radiation dose with color. So color meaning red is the high dose of radiation, green is intermediate, green to orange, it's a spectrum, same color spectrum we're using, and blue is cold, so that's low doses of radiation. And you can imagine that here is a prostate patient with a prostate that we're radiating. We bring the beams in multiple different directions. All of them are converging on the prostate, and you have a box that is where the radiation is common from all beams. And now you have a box of red hot tumor. With less doses going to the surrounding tissue. So that's the first technological development it started back in 1950s, 60s. That's 3D conformal radiation therapy, also abbreviated 3D CRT. You can imagine that we can bring the beams from many different directions. Here is 5 or 15 for that matter. And the more beams you bring in, the more conformal you're making the radiation. So here is 5 beams creating a pentagon, and it's sparing some of the rectum in the back and some of the bladder in the front. But still you're getting a good amount of dose, but with some sparing. Similarly, 15 beams, 13 beams, any number of beams you can bring from any directions. You can keep focusing the radiation, right? So that's one of the technologies, 3D conformal CRT, used all the time. The next advancement you have heard about is IMRT, intensity modulated radiation therapy. So what is intensity modulated radiation therapy? It's these big lead leaflets, we call these multi-leaf collimators, that are dynamic, that are keep changing and taking the shape of the tumor from different directions. So that's what does that do? That modulates the beam. So now going back to the previous slide, you see that inside each beam, the color is uniform. It's green, all uniform. But now with the modulating the beam with taking the shape of the tumor, now the beam is not uniform anymore. Now it's intensity modulated. That's what intensity modulation is. What it allows us to do is this curvature, the concavity. So it allows us to really shape the radiation dose to the tumor. And because of that, you're seeing so much more sparing of the rectum here. And I'll have a quick video to demonstrate how that works. So this is the gantry that delivers the radiation, and the patient is on the table. The gantry has built into it the multi-leaf collimators that are going to take the shape of the tumor and deliver the beam. Then it will go to the next position. So with this beam that was delivered, this is how the radiation dose is painted. And then it goes to the next spot, gives the next dose and the next beam, and so on and so forth. And each time it paints the dose, and finally you have hot in the prostate and cold in the rectum. Okay, so that's intensity modulated radiation. So the next advancement is, you can imagine you are going to have limited ability to have multiple different beams, right? From 15, 20. So instead, why don't we do it as an arc, which is an infinite number of beams? So an arc is the next development, which is arc IMRT, where the beam is continuously going, the MLCs are changing, and the dose is getting painted. And this becomes a very powerful technology, which allows us to deliver doses to even critical organs. Here is a tumor that's right in the center, around the kidneys and around the spinal cord and many other bowels that you're not able to see. But the MLCs are moving, the gantry is continuously in motion and delivering the radiation and painting the dose. And at the end, you spread out the cold spots all around, but the red hot is in the tumor, and you're giving the tumor very high ablative doses of radiation. So arc IMRT, again, it's built up from 3D conformal and IMRT, and that's how we do the arc IMRT. So the next development in technology is the image guidance. So we add 2 additional equipment. One is the source of the radiation. So you can see the gantry here. And then this is the source of an X-ray, and this is an X-ray detector. So by adding that As the radiation is going on, we can send an additional X-rays to generate a CT scan, an X-ray combined with to become a CT scan. So while we're delivering the radiation, now we're able to see where the radiation is going. So positioning and accuracy becomes that much important and available. And even before we turn on the beam, we can take a CT scan right there on the table and position the patient and move the position right to where we need it to deliver. So the next problem is motion, right? You may not think about it, but tumor inside you is constantly moving, not just lung tumors. This motion is happening to kidney tumors as well. I think I have another video for kidney tumor here. So here is the kidney, and you can see how much the kidneys are moving, and with it, the tumors will move. So how do we take into account motion? And that's one of the ways is what you're seeing here. This is an MRI. The one before that is a CT scan. So the ability for us to image in 3 dimensions, 4 dimensions now, the location of the tumor with the patient's breathing is what is called 4D CT. And with that, we can know where the tumor is at each part of the breathing cycle. And if we know that, then we can do multiple things. One of them is tumor tracking. So as the tumor is moving, our beam moves with it and it tracks the tumor. But there are other technology that I did not bring in here, like gating, where the tumor, when it goes out of the field, the beam stops, and when it comes back in the field, the beam turns on. So this is additional technology that allows us to now track the tumor. So with all of these technology combined and another next set, which is a body frame that has a built-in coordinate system in it, together now we are able to do stereotactic radiation, and that is what is called the stereotactic radiation, which allows us to give very high tumor ablative dose with minimal toxicity to the surrounding structure. So here is a tumor in the lung. Right next to it is the main windpipes, the main stem bronchus. Esophagus is right here that you cannot see very well. Spinal cord is right here. All of these are very critical radiosensitive structures, but even then we can give radiation dose, ablative doses to the tumor without harming any of these structures. It is done in 1 to 5 settings, which is also very convenient because we're able to deliver high precise doses. We can shorten the course from 7, 8, 9, 10 weeks down to only 1, 3, or 5 fractions or 5 treatments. Completely non-invasive and convenient and cost effective, and it does require technology, which we have here and we're developing more. So with that, now we're ready to talk about how we apply that to kidney cancer. I'll take a quick pause here and see if anybody has questions. We can have any number of interruptions. If you have questions, just interrupt me. Sometimes I'm not looking at the screen to see if anybody's raising hand or not. But nonetheless, any questions? Okay, so we'll go on to kidney cancer. So now, kidney cancer had a myth that it is radio resistant, and that myth came really from cell line studies that was done early in the 90s, where this French group took a number of human cancer cell lines, gave it 2 gray per fraction radiation, and kidney cancer happened to have been the lowest on the cell survival curve. So that pretty much condemned kidney cancer to be radio resistant. However, since then, a number of studies have looked at it, where they have given higher dose per fraction. So anytime more than 4 to 5 gray and higher, you see that these cell survival curve steepness is just as steep as any other cancer cell lines. So higher dose per fraction is something that kidney cancer responds to very well. In low doses, there is a little bit of what we call a shoulder. So there is a little bit of resistance, but 4, 5 gray and higher, it is very sensitive. And we have proven that doing animal studies where we have grown kidney tumors in nude mice, gave it 16 gray times 3, and that controlled the tumors very well. Clinically, overall, in clinical experience, in general, I have seen kidney cancer to be a lot more sensitive to SBRT fractionation than, for example, lung cancer, which needs a lot more radiation dose than kidney cancer. So with that, we'll go into covering primary renal. the application of SBRT for primary renal. So a little bit of background. Kidney cancer cases keep rising with increased use of diagnostic scans. But the small renal masses is something that typically are indolent. And we're talking about small renal masses that are 3 centimeters or less for the most part. And a large number of prospective as well as retrospective studies have been completed. This is a meta-analysis that is looking at them, that surveillance for these is an appropriate treatment option, whereas still 90% or higher renal masses are kidney cancer or kidney cancer variants. They on an average grow 0.4 centimeters per year, and overall 1/3 of the lesions do not grow, and 12% leads to progression. 1% progresses to metastasis. So provides good data to perform surveillance. When the tumor starts going 3 centimeters or higher, they start becoming more malignant and aggressive, and past 3 centimeters, the rate of metastasis start increasing. So that's when urologists will typically recommend treatment. So what is the treatment recommended right now in the NCCN guidelines? This includes partial nephrectomy, ablative techniques. So where is radiation? It is there somewhere in the subscript. You'll have to follow it down. And in my opinion, NCCN is a little bit behind on the data. Let's go over the data for SBRT for primary renal. So for small renal masses, the first study that published was done by the Kaplan group at Harvard quite some time ago. They just started with 7 gray times 3, fairly low dose, and then they escalated the dose to 16 gray times 3. What we learned from that is that overall local control was 93%. And interestingly, the only failures were in 7 and 9 gray groups. So we know that 10 gray or higher is what really is needed to control kidney tumors. The other interesting thing is the enhancements did not change as a result of this radiation. So enhancement is the dye getting taken up by the tumor, and often that is because of the vasculature, and kidney tumors are very vascular. So in the arterial phase, they will enhance. And urologist always looks for the destruction with their ablations, the destruction of the vasculature and lack of the enhancement as the sign of local control. With radiation, though, it kills by DNA damage and does not necessarily disrupt the vasculature. So enhancement still remains, but the tumor does shrink, as you can see in this waterfall graph. So one of the first studies. And the second study was a feasibility study published by Dr. Shiva's group at Peter Mac that enrolled 37 patients, gave it 26 gray times 1 or 14 gray times 3, and reported a local control rate of 100% with grade 3 toxicity of 3%. So this was a good feasibility study. It did show that there is some decline in kidney function. So we not too long ago published the first phase 2 study where we enrolled small number of patients, 16 patients with kidney tumors less than 5 centimeters, and we treated with 8 gray times 5 or 12 gray times 3. We applied a rigorous endpoint of pre-treatment biopsy comparing with post-treatment biopsy to confirm tumor control, as well as radiographic endpoints at 1 year post. And what we learned is that we reported a local control rate of 94%, so only one patient failed. We learned that on the right graph on the right, you can see that the tumors were steeply growing, and then the curve slowed down significantly after the radiation and started to regress in most of the cases, not all the cases. And in only one patient that it continued to keep going. We biopsied pre-radiation and 1 year post-radiation. And what we see is shown here. Left is pre-treatment, where you see a lot of clear cells. And post-radiation, there is significant reduction. So decreased cellularity. You see the pink is the hyalinization, so a lot of scar tissue formation or hyalinization. And then the red is the necrosis, so you see a lot more necrosis. So there is 100% of the patients, every single one of them had signs of radiation-induced local control of decreased cellularity, increased necrosis, and increased hyalinization. However, the urologist noticed that there is still some rare tumor cells that are present. And based on that, every single patient, they would actually call out and say, oh, this is a sign of viable tumor, or this is a sign of failure. Every single patient. Yet, radiographically, 95% or even 100% was actually controlled. So how do we reconcile that discrepancy? So then I went back to the pathologist and I said, listen, there's cells, maybe the cells are not dividing. Can we check if the cells are dividing? So then we developed a dual staining with carbonic anhydrase, which is the marker for the tumor itself, and Ki67, which is the marker for cell division. Here you have the Ki67 in brown and carbonic anhydrase in magenta in membrane, magenta membranous staining. So if you look at high power, you see a number of cells that have membranous staining, but none of those cells have the brown staining. The brown stainings are mainly on the endothelial cells or fibroblasts that are in the stroma. So these cells clearly are not dividing, the tumor cells. So if you have a tumor cell that is not dividing, do you still call it a tumor cell? Recall that all cell survival graphs are looking at colony formation. All treatments with chemotherapy, they look at colony formation, meaning the ability of tumor cells to divide. So if a cell is not dividing, you technically cannot really call them tumor cells anymore. So we hypothesize that these cells perhaps are in senescence. So and senescence is a state of irreversible cell cycle arrest. So to investigate more, we applied the nanostrings digital spatial profiler and do spatial transcriptomic and proteomics. And these are some of the few translational aspects that I have in my talk, which I did not focus on, but in the future I probably will focus more on this. But we applied the nanostring platform and working closely with the pathologist, we started picking regions of interest, so ROIs in pre-treatment and the same patient's biopsy post-treatment. We applied multiple staining, including nuclear and carbonic anhydrase, and the exclusion staining that excludes non-tumor cells. And by doing this, we focused down to almost single cell level on the tumor cells and the rare tumor cells that remain. Then we performed the spatial transcriptomics, which showed a decrease in apoptotic markers and an increase in senescent markers. We confirmed that with proteomics in the same setting and in the same platform, that again showed that there is an increase in senescence markers. And then finally, we went back and confirmed these with another immunohistochemistry of P16 that showed indeed post-SABR there is much higher levels of senescence markers. So we confirm that radiation, of course, in earlier time points, perhaps has cells, kidney cancer cells that go through apoptosis, mitotic catastrophe, and other types of cell death. But 1 year post, whatever cells, rare cells that remain intact, they are in senescence and they're really not dividing. So many other studies looked at also local control, and here is one of them that combines them in a systematic review or meta-analysis that shows an overall local control rate of 97.3% with a toxicity rate that are high grade of 1.5%, which are really, really good numbers. Then we combined with the IROC institution our retrospective experience of one of the largest series of 190 patients and reported a similar local control of 95%. Again, you see some decline in EGFR for these patients. The most recent study published in Lancet Oncology last year was the Fast Track 2 that enrolled 70 patients with small renal mass treated with stereotactic radiation. The fractionation of 26 gray times 1 or 42 gray times 2. They reported again a local control rate of 100%, but grade 3 toxicity this time was a little bit higher. It's at 10%, and I do believe that we perhaps don't need to go that high in the radiation dose and find the right balance between toxicity and local control. Any questions on stereotactic radiation for small renal masses?
Raqui, do you think, I mean, there's not really, my question is, do you think there's a need for a randomized trial? It's just not the kind of thing that lends itself to that in this setting. I mean, we're starting to do it more institutionally, and but in more frail patients or non-surgical candidates. But you can make an argument that they don't have to be a non-surgical candidate, right? I mean,
yeah, so I'll show some data a little bit later on comparing stereotactic radiation with ablative techniques, which has been done in systematic review, but nothing compared head-to-head surgery and radiation. And I mean, ideally it would be great to do a randomized trial, but would we have patient buy-in and enrollment is the question. Which, I mean, we know from our prostate experience and many other sites, whenever you're randomizing, it's difficult to accrue patients. And remember,
yeah, I don't think it could ever happen. I was just sort of asking is, how do you get this to be more accepted? I mean, I think institutionally for us it is, but I'm sure that's not the case
no,
universally.
institutionally for us that is also the case, but you're
Yeah,
absolutely
sure.
right that out there it's not. So, and I don't have a good solution other than what we are doing in IROC is a prospective registry study to get really long-term local control data,
Yeah.
and perhaps that will get accepted. And in the future, remember in the prostate cancer, the PROTECT trial, the only place to enroll was Europe, where patients kind of did not have a choice, and they were given either surveillance or radiation or surgery. And then they were able to follow and get the really high level evidence. I don't know if that will be possible. It's definitely not in the United States, but perhaps in other settings.
Thanks.
So going on to a little bit bigger tumors. So T1B and the data starts becoming really less with bigger tumors. So this is another IROC publication that median tumor diameter close to 5 centimeters, but there was tumors that were going into 7-8 centimeters, and reported a local control rate that was fairly good at 9.97% with reasonable toxicity. So there is some data, not too much. So here is the data I was talking about, the comparing to ablation. So this came out actually last month in Lancet Oncology. The Canadian group did a systematic review and reviewed 8,000 patients from 133 studies. And these are primarily small renal masses that are 5 centimeters or around 5 centimeters or less. And these were, of course, treated with SBRT, radiofrequency ablation, microwave ablation, and cryoablation. And what they learned from it is that here's the summary of the outcome. So what you see is that overall, when you take all tumors, the local control rates, and these are local control rates at 5 years that I highlighted. SBRT is 95%, radiofrequency ablation 92%, 86% with microwave, and 90% with cryo. So these numbers are all fairly good when you group everything together. But when you separate it out by less than 4 centimeter versus greater than 4 centimeter, with less than 4 centimeters, everything is 90% or higher. But tumors that are greater than 4 centimeters, now you start seeing SBRT still holds well above 90%, where some of the ablative techniques now starts coming down to lower 80s. And this was significant with the p-value. So for sure, for small renal masses that are smaller than 4 centimeters, you have multiple good options, including stereotactic radiation, which of course is non-invasive, versus the other ones being minimal invasive. There are other differences that I did not go into. The location-wise, there is a lot more limitation with ablation and a lot less limitation with stereotactic radiation. But for sure, 4 centimeter or higher tumors, it is well known that for ablations, you would need to do repeat ablations, whereas with stereotactic radiation, you still get 90% or higher local control rates. So what about tumors that are even bigger? T3 tumors that are IVC tumor thrombus. So we had some experience, mainly anecdotal, where we published case report of 2 patients with these large IVC tumor thrombi that went past the diaphragm into the right atria. So these are level 4 thrombus. We radiated them. These patients mainly were refractory to surgery and systemic therapy. We gave them very high dose of radiation of 45 to 50 gray in 5 treatments. And in one patient, we had the radiographic evidence a year later. The tumor shrunk significantly. So here is the one before thrombus, before radiation, and you can see that it really has significantly contracted 1 year post. And the patient also felt significantly better with resolving of his Budd-Chiari syndrome, which comes from the venous congestion in the liver. So that got us going. So we started talking to multiple other institutions to collect cases and we were able to put together a case series of 15 patients with IVC tumor thrombus that we treated with radiation, and almost nearly 60% of them demonstrated radiographic response. All patients derived palliative benefit, and we are now expanding the study to update, and we have about 50 cases. So one of the cases that we published, I'm going to take you through. So here is a patient, a 38-year-old lady who presented with this IVC thrombus in the setting of large left kidney primary. And she had clear signs of the venous congestion, which is pointed out here. In this MRI, you see the ascites that is all around the liver. In another sequence, you see that the liver, you see the right side of the liver is hypoperfused. So it is a little bit more darker. And here the radiologist is pointing out with the white arrow that the right hepatic vein is engorged, whereas the left ones are not engorged. So this is the vein that has occluded and started the venous congestion. So the patient clearly had the Budd-Chiari syndrome, which makes surgery very difficult and morbid. The mortality, I think, increases more than 10%. So surgery was not an option for this patient. So we started the patient with EP-Nivo, the checkpoint inhibitors, and then at the same time we did radiation, stereotactic radiation to the thrombus. And after that, we see within 6 weeks, there is already the LFTs, the liver function enzymes, became normalized within 6 weeks. And at 7 months, what you see here is the ascites resolved. You see that the perfusion is now homogeneous throughout the liver. You see that the right renal vein is not engorged anymore. And now the Budd-Chiari has resolved, and now the patient became candidate for surgery, and she safely underwent nephrectomy and thrombectomy. So this is one of the places where we really can start integrating stereotactic radiation. I'll give you another case report. This is another patient that presented with IVC thrombus on the with left kidney mass. But our radiologist pointed out this irregularity in IVC wall, meaning that the thrombus has invaded into the IVC wall, meaning that even if you do surgery, that will become a really complicated surgery where you have to resect part of the inferior vena cava. And the patient clearly was not a candidate for that. So then what we did is we performed the nephrectomy only and not the thrombectomy, and gave stereotactic radiation to the thrombus that was left behind to give the patient full local control. And this patient is now doing well. So we went ahead and designed a phase 2 clinical trial of IVC thrombus where we give radiation before the thrombectomy. One, to try to kill off the thrombus, improve local control, but second, also to reduce systemic recurrence, which may happen from the surgery and the surgical manipulation of the tumor during the surgery. So we kill off the thrombi, then patient undergoes surgery. We completed the safety lead-in phase of this trial and published some time ago. We actually now finished completely enrolling the trial. We hopefully will get the manuscript out soon. The interesting thing we did notice in this trial is initially we allowed enrollment of metastatic patients, and out of the 3 metastatic patients, 2 of them we saw this the abscopal effect, which you may have heard about. So the abscopal effect of radiation is when you're giving radiation to a different site and a metastatic tumor is responding. And that is hypothesized to be coming from an immune response starting from the tumor. Something that I probably would focus in another talk a lot more. But here is one of those patients who had a metastasis in the lung, but we radiated the thrombus. And after the thrombus radiation, this is 1 month prior, 3 months prior, the lesion looked bigger. So we biopsied the lesion. But after that, spontaneously, the lesion started regressing. And not only 12 months, now it's 4 years out. The patient is still doing very well without any recurrence of cancer. The biopsy that we did, we analyzed in a lot more detail. And just immunohistochemistry showed a very robust infiltration of CD4, CD3, and CD8 cells, in addition to macrophages, which is CD68. We did a quite bit more translational studies on this that I did not bring in here. So what about T4 tumors? what can we do with T4 tumors? So these are tumors that have invaded into different organs, and they're really large. Can we treat them? To talk about the treatment, I have to introduce you to another new technology that we developed, which is called PULSAR, the personalized ultrafractionated stereotactic adaptive radiation. So this is adaptive radiation, and we are adapting to tumors change with radiation. So what is PULSAR? It is adaptation. We give an initial radiation plan and delivery of a big dose, and then we give time because the tumor needs time to change. After giving time, the tumor shrinks, and once the tumor shrinks, now the normal tissue is occupying the same area that tumor used to occupy. So if you don't change your radiation plan, then you would be delivering radiation dose now to the normal tissue, and you will really not be able to deliver very high dose and incur unnecessary toxicity. So the hallmark of this is to give time and then adapt to position and to shape. To give you a real life example of adaptation and what happens if you don't adapt, here is Mick Jagger, singer, at age 20. And by age 50, he looks like this with no adaptation. I mean, you could do some facelifting and other things. But on the other hand, if you adapted, this is what you may look like. The same exact how you looked at age 20. But joking aside, if you have a tumor that is shown here, you give one pulse of radiation. Now the tumor you may analyze a month later that the tumor has gotten bigger. So now you're thinking, okay, the tumor is really radio resistant, or maybe this is inflammation. So maybe we increase the radiation dose. So you increase the radiation dose. Finally, now you have a tumor that is responding. So this is adapting by shape and in size and by increasing the radiation dose. Then you keep giving pulses, and at one time the tumor shrinks very small, and then maybe think about consolidative drug. On the other hand, if you give the first pulse and you see that the tumor is already shrinking, then maybe you don't need as much dose. You definitely shrink the radiation field, maybe radiation dose, and keep following, and then it disappears. So this is based on shape. You can imagine that we don't have to adapt only based on shape. We can adapt based on tumor, biology and histology, genetics. You can adapt based on tumor microenvironment or any other number of host factors. So you interrogate with biopsy lab results or imaging, and based on the interrogation, you have a directive where you intensify or de-intensify or change the radiation plan accordingly. So what is the benefit of PULSAR? The split course increase in space is much less toxic. Long interval allows and facilitate adaptation. And the last one that we think is also long interval between pulses allows for adaptive immunity, because radiation is a hypothesis that it brings in the dendritic cells that can do antigen presentation. And if you don't allow enough time and bring in the next radiation dose too soon, then you're killing those cells. But by spacing it out, now you can follow a cancer vaccination schedule. So here is an application. There is a T4 tumor, a tumor that is clearly invaded into the liver. This is a patient that was started on Ipi/Nivo, and this patient kept having hospital admissions due to multiple bleeding through the urine, so hematuria, and this was not being able to be controlled by embolization and any other techniques. So they were referred to us for palliative radiation. And we started the radiation with a very big and large radiation dose. And you can see the blue cold on the outside, which is abutting the radiosensitive structures, with red hot inside. So we are really giving high doses in the middle, but keeping it cold on the outside. We give the one radiation and then we wait a whole month and then give the second radiation and adapt each time. And what we noticed is over time, after each fraction, the tumor kept shrinking to give it final, what it looks like is something much smaller. And then we finished the 5 treatments and we kept following the patient. And this is 1 year out, where the tumor now is completely controlled. It keeps shrinking. Even a year out, it keeps shrinking. It's almost out of the liver, as you can see. But overall, the tumor is completely controlled. The patient is actually doing very well now. So this is an application of T4. There's not much data, it's just a case report. Hopefully we'll publish more cases down the line. But this is really something that we have that gives us a great power. And yes, you may think that this sayings came from our friendly neighborhood Spider-Man's Uncle Ben, but it actually came from Voltaire. And with this great power, it does come, the onus is on us to find out where are all the places where we can apply it to improve our patient's outcome. And one other perhaps places that we can apply is in situ reduction for primary kidney tumor. And this is now being investigated. So there's one pilot study that was published that looked at situ reduction in the setting of metastatic cancer, where we give radiation to the primary tumor. And then the tumor gets surgerized, and they looked at different markers and interestingly showed some activation of the immune markers as well. It is being investigated in 2 randomized phase 2 studies, one cytoshrink that has completed enrollment, and hopefully we'll see the publication coming out soon. And the second trial is Samurai, which is now enrolling all of those, both of them in the setting of checkpoint inhibitors. So very interesting studies. So a little bit on salvage of primary kidney cancers after radiation. So these are the patients that had local recurrence after surgery or ablation that were salvaged. Not too much data on these. So one retrospective study from a Chinese group looked at 2,000 some patients had nephrectomy and had about 106 of them that did have recurrence. And some of them were treated with systemic therapy and others treated with local therapies. And the local therapies was surgery and stereotactic radiation. So they did resurgery to salvage them, or some of them they did stereotactic radiation versus giving systemic therapy for these patients. And what they found was that for the most part, local therapy did much better than systemic therapy. Not something that is surprising, of course. IROC published a small study of 17 patients looking at ablation recurrences and salvaging ablation and reported a local control rate of 100% with stereotactic radiation. We are now looking at, and this is unpublished data, we are now looking at our own series where we identified 21 patients that had local recurrence after radical nephrectomy or partial nephrectomy, and we were able to salvage them 95% of the time with stereotactic radiation. So this is perhaps a good place for me to pause or perhaps even stop, because I don't know if I will be able to cover the rest. But let's first pause for questions. Any questions?
Yeah, Raqui, I don't know. We have about 15 minutes. I'd love to hear a little bit about metastatic. I don't know if it's too much to squeeze in, or you want to maybe just talk about, I think it's the oligo-met, more than oligo-progressive that probably be relevant to this group,
Sure.
unless you just think it's too much.
No, let's in that case, let's cover oligo-met and briefly
And then we can
oligo-progression,
pause for
and then
questions.
we can wrap.
Sounds good. Thanks.
Perfect. So first, so to go into oligo-met, we first had to confirm that stereotactic radiation works for metastatic patients. And this is just a retrospective study. What I wanted to highlight is that, and this is one of the largest studies that we published, I wanted to highlight that the median follow-up was really low at 18 months. So long-term local control data for metastatic setting with SBRT for renal is not still available. We are going to publish very soon our experience where we have now 4 or 5 years of data, and the local control still holds at 90% or higher. So in this retrospective study, we explored what was pertinent to having local failure. I'll move on in the interest of time. And so there's other studies that is reported overall local control rate close to 90% for metastatic setting for SBRT for renal metastasis. So now oligo-met is where you're applying sequential radiation to control the disease overall. Now we know a large number of surgical series that look at surgical metastasectomy that showed overall survival benefit for these patients, but all of those studies are retrospective, which are prone to bias. And even a systematic review coming from those retrospective studies showed overall survival benefit for oligometastatic metastasectomy patients. So we were the first to apply sequential radiation for systemic therapy naive patients with stereotactic radiation and controlling them. So as the patient develop metastasis, we'll keep applying stereotactic radiation to keep controlling them sequentially. And we learned in the retrospective setting that the median PFS was 15 months, which was fairly significant at that time when systemic therapies were not as advanced as now. The median PFS of systemic therapies was on the same level. The 1 and 2 year overall survival rates were very good. So we went on to look a little bit on what factors these patients would benefit from doing this. And we identified some factors. These are the older studies. So I'm going to show you the newer study where we expanded this study from that 48 patients to 153 patients of oligomet, the same patient population. And this came out just last month. With median PFS, we reported of 32 months. So we were almost nearly 2.5 years that we were able to control these patients just with sequential radiation. But more importantly, we applied machine learning and CPH modeling to identify which patients really benefits from this strategy. And we learned that the number of metastases at presentation, 1 versus more than 1. So 1 did better than 2, and 2 did better than 3, and so on and so forth. In addition, metastasis to bone and brain did much worse. So these are patient selection criteria, which helps us select the patients that would benefit from sequential SABR strategy. So the patient population, of course, to focus on is the low IMDC risk groups, which have a much longer PFS, because the higher risk groups, you don't want to delay systemic therapy. And we went on to do a phase 2 single arm study, applying the same strategy that confirmed these findings. We are publishing an update of this study now, where we have a median that has gone past 3 years. The interesting thing on this study, though, is we did patient-reported quality of life outcomes before and after radiation, and we confirmed that the quality of life did not change for these patients. As you can see, that the patients had low levels of grade 2 or higher toxicity. So MD Anderson confirmed their experience. This is actually the UK study. On the left is the UK study, on the right is the MD Anderson experience. UK did a multi-institutional prospective registry trial of 143 patients of metastatic RCC, oligometastatic RCC treated with SABR, and MD Anderson did 30 patient feasibility phase 2 study. Both of them confirmed these findings. So we went on to design a large phase 3 randomized study where we do just that. We randomize the patient to receive sequential SABR, and at progression, we do systemic therapy, versus in arm B, we are doing standard of care systemic therapy. The reason that this study is needed is because you don't know by delaying systemic therapy whether you really are harming the patients, because you're allowing the micrometastasis to progress. And in doing that, the patient may have less overall survival. So this study is looking at non-inferiority of overall survival. And if we're able to achieve that, then for sure, toxicity-wise and quality of life-wise, the patients do better with sequential SABR. And this is a significant gain for our patients. So very briefly, very high local control rates for metastatic RCC for brain metastasis, and a little bit less for spine metastasis. And Brian, do you want me to go on to talk a little bit about oligoprogression?
Maybe let's pause. I had a question
Okay.
on the oligomet, and if other people do as well, then we can see. I mean, I think the ECOG trial is absolutely critical, and I credit you and the others for doing it. If you go back to, there's no question the local control is great with SBRT. I think what I struggle with is, when we're radiating small asymptomatic things in patients, I'm pretty sure that not all of them need it. Do you know what I mean? Like it's hard for me to believe that we're helping everybody by doing that. We're probably helping some, just like a drug, right? We're not helping everybody with a drug.
Exactly.
And so, that's in clinic. That's what I struggle with. Like, we can do it. Of
Yeah,
course we can do it, but I don't know that we should do it for everyone. And so I think this study will be critical. Now, it's really just delayed systemic therapy, right? Is the ability to delay systemic therapy. I would argue that there's a subset of patients in this trial who could probably just be observed for a while and then get systemic therapy.
I did not bring in your data, which actually I had the slide. And you published the active surveillance group and showed really impressive PFS in these patients. Yes, you're absolutely right. that some patients don't really need the treatment. But I mean, there's multiple things to consider. One is we don't know when that biology will become aggressive and at what size the risk of metastasis starts increasing. And eventually also there is a patient factor. I mean, I think you probably cannot ignore the psychology of the patient. If you tell them you have metastatic cancer and we're going to watch it versus we are going to get rid of it with ablation or radiation, I think there is a factor of anxiety. As you know, from again, extrapolating from prostate cancer, anxiety is also an indication for not doing active surveillance. So there are multiple issues, but yes, prospective high-level
I
data
think
is needed.
you and I should debate this on a stage somewhere. I've never had a patient refuse surveillance. We actually measured anxiety in our observation study and didn't really find anything. Most of my patients, and again, I think it's all in the approach, right? It's all in how you present it, are happy that they don't need treatment, but I take your point. It's just, I think it's going to be one of those things that you can't randomize, et cetera, et cetera. It's just going to be one of those things. But I think this trial is really important to at least say the survival is not inferior. I don't, I mean, if it's superior, great, right? Then it's a game changer.
Right. I mean, exactly. We don't expect it to be superior, but we don't know until we do it. This study will interrogate that as well. But initially, as long as it's non-inferior, then this trial will be declared, practice changing potentially because you're really benefiting the patients. And at the end, I think the biomarker and biopsy and even ctDNA and other things is really something that we need to investigate to give us a clear answer of what is better for which patient.
Why don't we just in the last few minutes just do other questions? We'll save oligoprogressive for another day.
Yeah, absolutely.
Thanks for that great talk. Clinically, this is all super relevant, right? I mean, it's happening a lot. Every tumor board we're talking about this for patients. So I'm glad there's emerging data and trials, et cetera. Sorry, let me get back on camera here. Anybody else? Questions, thoughts? I think some of the. Go ahead.
Yeah, quick question. I saw a little bit of the data on non-clear cell RCC. Do you have any other thoughts, or is there any updated data out there? Because that comes up for me in clinic sometimes.
Absolutely, absolutely. So we are updating, as I told you, our retrospective experience. We now have about 600 or so patients with larger number of lesions. Out of them, non-clear cell is about 100 plus. So we will have very good data. So far, just what I know even before publication is that there is no difference in local control rates between clear cell versus non-clear cell with stereotactic radiation. So in our smaller published studies, we have already noticed that, like the oligomet trial, there was no difference, but that was just a handful of patients. But yes, larger series is coming. So far, no difference in local control between clear cell versus non-clear cell. And that's really very relevant because non-clear cell often patients do not have as much option for systemic therapy. So the oligomet and oligoprogressive settings become that much more relevant.
That's great. That's good to know. Thanks.
I have a question. Can you hear me, Brian?
Yeah, we can hear you.
Yeah, this is Rainier from University of Wisconsin. Awesome presentation. Very interested on the radiation vaccination effect. So have you planned or try to use SBRT as a neoadjuvant for immunotherapy? And because we have a very big interest on that combination of radiation and immunotherapy here at UW, but wonder what your thoughts are on those.
Absolutely, and we should probably chat offline sometime. And that is the last part of my presentation that I highlighted as iSaber, Immune Saber. So we are so a lot to talk about there. We had a number of clinical trials that we completed. The high dose IL-2 trial that we completed, which was not positive. Then there is the RADVAX trial, which was also not really published. The NEVES trial has been completed that has not been positive, but none of them really used pulsar radiation. And pulsar is where we use a cancer vaccination schedule to space them out to allow time for that whole process of adaptive immunity to take place. So our latest trial is the SPARK trial, which now is actually there registered in clinicaltrials.gov. You will be able to find it, where we are combining an intratumoral STING agonist, which we have a strong preclinical data to show that it enhances the antigen presenting ability of the radiation. So we will give and this is all in the setting of oligoprogression. So patients that progressed or have oligoprogression on AP-Nivo and on maintenance Nivo, those are the patients that oligoprogressive site. We will give 1 pulse of radiation and give intratumoral sting agonist injection, followed by 2 weeks later, the same exact thing again, and again a third time. So 2 booster injections and pulses from radiation. And then we will see if we are able to induce systemic response or immune response or enhance the immune response of the maintenance Nivo for these patients. So a feasibility study. But yes, we are working on it. It's an active field of research, and it's my personal interest of research that I do in the lab. So really happy to talk about it sometime. And that whole part of the presentation, maybe we'll do in another time.
Yeah, we'd be happy to have you back to talk more about lab-based stuff. That'd be great. I think we're going to wrap up in the interest of time. Like, I really appreciate your time and expertise. Thanks everyone for joining, and we'll see you all soon. Maybe some of you at ASCO.
Thank you so much for having me.
All right. Have a good day,
Thank
everyone.
you. Awesome.